My name's Ian Duncan. I'm an actuary by profession. I run a small actuarial consulting firm that specializes in what we call value-based contracting, not more than a few miles from here in Sunnyvale, actually. I'm also a professor at the University of California. I'm going to talk a little bit, picking up on what Joe Ellen said about some of the approaches that companies, our clients, are taking to get reimbursed. So we deal a lot, being in Silicon Valley, we deal a lot with startups, being device companies, provider companies that have programs for different kinds of interventions. And they come to us with some new device. They've started a new healthcare company of some kind. They've obtained certification, but they generally start much too late in the process figuring out how they're actually going to get paid. And as Joe Ellen said, it's all about the deep pockets, namely the insurers. So I'm going to talk a little bit about what payers care about, what kind of evidence you need to support your value proposition, how much is enough evidence, and then calculating ROI, sometimes without real world data, very frequently for startups without real world data. This is me, as I said, a professor at the university. There's a couple of things. I do this talk a lot, and this may interest some of you, may not, but these are a couple of things that if you want to pursue this a little bit further, I talk a lot at something called the Rosenman Institute at UC San Francisco, where I'm on the board. And I do a presentation on how to get paid for value. And I also recently wrote a chapter in a new healthcare textbook on value-based contracting. So both of those are free if you're interested. So what do payers care about? And the payer here could be an insurance company, it could be an employer, it could be some kind of government payer. So if you want to capture the value of what it is that you're presenting, you need a financial value proposition for the payer. I assume that you've got a clinical value proposition and that the medical directors are on your side. But as I say at the bottom there, you need to convince the actuaries who support the payers that you have a financial value proposition. Sometimes it's useful to be able to go to a payer and be willing to take risk, financial risk, but you definitely need to understand the economics. And that sometimes means entering into a value-based contract. And you certainly need to follow up with the kinds of operational support that allow you, if you're going to enter into some kind of risk-bearing contract, you need to be able to deliver on that contract. Too many of our clients, I think, enter into the contract and just assume everything from there is going to go just fine. But it really requires a lot of focus, because it's not just a matter of clinical intervention and clinical support. In order to achieve a good financial outcome, you need to manage a project, manage an intervention to achieve the financial result. And as I said, I'm an actuary myself, which is useful, I think, for our clients, because very frequently the actuaries in the payers are the gatekeepers. The natural inclination on the part of actuaries is to say no. They've seen everything that you're going to bring to them. They've seen it before. They know it doesn't work. They know it will not save them money. And they sometimes will tell you politely no, and they'll sometimes be much less polite than that. But generally, you've got to overcome this lethargy on the part of my actuarial brethren and sisters. There are two important definitions that you need to know when you're talking to a payer. The first of these is per member per month. The per member per month is the language that actuaries work in. They want to know that what you're going to do is going to reduce their cost on a per member per month basis. Per member per month is calculated as the total medical plus administrative cost for providing the services to their populations, divided by the total enrolled member months. Your objective with your device is to reduce their per member per month cost. Sometimes they're also interested in something called the medical loss ratio. This is particularly true of government payers. Medicare Advantage plans. And a lot of our clients are going after Medicare Advantage because nearly half of Medicare's membership is now in Medicare Advantage, and there's a lot of money on the table in Medicare Advantage. The medical loss ratio is defined as total medical plus admin cost divided by a different denominator. Here it's total revenue. But in both cases, your objective is to reduce these two things in a meaningful way. What do we mean by meaningful? My rule of thumb used to be that in order to get the attention of an actuary in a health plan, you ought to be able to tell them across the entire population of the health plan that what you're going to do is going to save them at least $1 or $2 net. Now, anybody who's ever managed a health plan or an employer plan will tell you that although that doesn't sound like a lot of money, it's actually very difficult to do something that will actually get the cost down by $1 or $2 per member per month. But that's my general rule of thumb for an employer health plan or a commercial health plan of working adults. In the Medicare space, it's a little bit more because Medicare costs on average about twice what commercial health plans cost. So you need to be able to save a few dollars net of whatever it is that you're going to charge for your device, whatever is going to get paid for your device. The other thing that we have to deal with when clients come to us is this question of whether there's a there. And by that, I mean a financial there. If you have, as one of our clients once had, a new test for Lyme disease, he had developed this as his PhD project. Apparently, it was very accurate at identifying Lyme disease, and he was very excited about it. He started a company to market this. The problem with Lyme disease, when you look at the claims data, which is, again, the commodity that we deal with as actuaries, when you look at the claims data, the claims for Lyme disease in the average plan are about $1.20 per member per month. There just isn't enough money on the table to interest the payer in a new test for Lyme disease. So you've got to be able to address either something that is very high cost and potentially with a relatively small n, or something that is less costly but has a larger n, which is why we see so many programs and so many devices in cardiac, diabetes, and so on, because they're very large n's, even though the cost is perhaps not all that high on an individual basis. But my first and most important point is there a there in whatever it is that you want to interest the payer in? We've talked about PMPM and some ballpark numbers in terms of how much you need to save on a PMPM basis. It's important also to figure out whether what you're going to do duplicates something that's already been done. Does it replace something that's already been done? Is it more costly than something that's already been done? How do the economics work in terms of substitution? And is there internal competition? This is more true of programs than it is of devices. But very frequently, there are large, sometimes large, groups of people inside a payer who are in favor of some alternative to whatever it is that you're proposing. And they are an obstacle in the way of your adoption. Engagement with patients is important. How do you get engagement with patients? You've obviously got to be able to sell the providers on it, which means you have a whole different economic case to make. If the provider is going to be paying for some new device, then you've got to be able to convince the provider that the economics are there, which is a lot more difficult sometimes. I talked earlier about my ballpark number for how much you have to reduce a per member per month cost by. Sometimes payers talk in terms of return on investment. If they're going to be paying for some new device or program, they want a minimal return on investment. And my rule of thumb there is you need to be able to provide them at least double the cost that they're going to be paying you in terms of how much you're going to save. Sometimes more, because it's very difficult, as Joe Ellen said, it's difficult to measure accurately the savings in these kinds of programs, extremely difficult. The variability in healthcare costs is so great that it's a real challenge to do a credible outcomes analysis. But if you can convince the actuaries that there's going to be at least a credible 2-to-1 ROI or perhaps 3-to-1 ROI, then at least you get your foot in the door. Sometimes important HEDIS quality measures are important, particularly in the Medicare Advantage space. This can sometimes be helpful with star ratings. And then you've got to take into account patient turnover. A health plan or an employer is not going to invest in a product that has a longer term return than the next 12 to 18 months. They can't guarantee that that individual will still be insured with them 12 to 18 months out. So we talked about ROI, my rule of thumb, 2-to-1 ROI. Other measures, you've got to be able to convince them that it's not going to cost them a ton of money to implement. And is it something that they have the resources? Health plans are notoriously short of resources, and they don't, in my opinion, do a terribly good job of implementation. There are at least 2 buyers in the health plan, the chief medical officer and the actuaries. And what kind of evidence do you need to be able to convince these folks? Joe Ellen talked a lot about FDA and clinical evidence, the peer-reviewed studies, and sometimes white papers. If you have other client results to put in front of them, some real-world evidence is always extremely important. If you lack real-world evidence, what we do for clients that is generally quite successful with the actuaries is an economic model that demonstrates with real data, but with clinical input, how much an episode of care utilization can be reduced. Clinical expertise is important for this, and then sometimes survey data, but I'm not particularly in favor of survey data. You can calculate ROI without real-world data. If you've got some real-world data, great. If you don't, then the economic model approach is quite useful. If you don't have dollar outcomes, at least if you can demonstrate with, if you've, for example, gone for FDA approval, if you have utilization reduction, that can be linked to financial information to calculate an economic model. Sometimes clinical expert estimates can be useful. My word of caution is to beware of data from external sources that you don't have control over. Very frequently, clients come to us with data that they've obtained either on the internet or from advocacy societies. The problem with this is it's very unlikely that that data contains specific financial information or even utilization information for the population you are likely to address. If you think about it, if you look at healthcare expenditure in the United States, it takes in everybody, Medicare, commercial, uninsured, Medicaid, everybody. But if you're talking to an employer, you need the employer subset of data in order to have a credible conversation. No actuary would believe you if you came with data that came from some sort of unreliable source, like a national study or an advocacy society. It's not easy to obtain evidence, but sometimes you can do a pilot. Insurance companies may occasionally do pilots, but they are very wary of them because they involve much more effort on the insurer's part for uncertain return. The economic model approach is useful. If you're willing to go at risk, if you have sufficient courage and financial backing to take a financial risk, then that can sometimes be useful to convince a payer to give you a try. It's important to have a model to identify the right candidates, because where ROI goes astray is if you distribute your product to too large a population, too large and unfocused a population. If you expect to see a financial ROI, you need to focus on those patients that will give you a financial ROI and not spread it too broadly. Remember that ROI has a numerator and a denominator, and the denominator is how many people or how much cost is involved in your program or your pilot. So Joe Ellen touched on this slightly, and I'm going to talk just briefly about this notion of value-based contracting, because this is where everybody is headed nowadays. Joe Ellen's discussion was very much focused on obtaining fee-for-service reimbursement for CPT codes for specific services. But I would say that for various reasons, the industry and the payers are moving towards more global kind of contracting, where you take some kind of financial risk for the financial outcomes for a population. There's been a whole evolution of value-based contracting over the last 20, 25 years, all the way from pay for quality to full capitation. And somewhere in the middle there might well be a solution for a new client or a new startup. What's interesting is how rapidly the market is expanding. CMS is pushing payers in this direction. They expect that traditional Medicare will be, and Medicare Advantage, will be in 100% value-based contracts with payers by, or providers rather, by 2025. Commercial, less so. I think employers find it a little bit more difficult to contract with providers in this space, but even there's been significant growth in various kinds of value-based contracts. Value-based contracts could be anything from, going back a slide, could be anything from just paying for some kind of performance to risk sharing or gain sharing. If you can demonstrate that you've actually saved money for the payer might be willing to share in the gains with you. There are all sorts of complications about how to set up a contract like that and how to measure it, but it's very much worth considering. Or, of course, you could go to bundled payment if there's an episode of care or some kind of full capitation for some subspecialty. So that's my talk for today.